All right. So, Assalamu alaikum. Good morning,
Walaikum salam.
good evening, good afternoon, depending on where you are. We welcome you to the nationwide monthly academic meeting, which is jointly organized by APPNA peers and academic neonatology community in Pakistan. We have been doing these monthly sessions, and I think they are getting exciting every time we meet. And this time, this is our third session on PDA, the same topic. We're literally going to kill the PDA. So this time we have wonderful speakers. We have Dr. Hasnain Mirza. I don't know if all of you know him. Dr. Hasnain Mirza is Neonatology Fellowship Director, stationed in Florida. He's a good friend and he has ton of experience dealing with PDA in newborns and premature babies. We also have Professor Zahed Amin. We never met. I think this is our virtual meeting and we will get to know about him. He is a professor of pediatrics um, in Florida as well. He's right now with Advent Health, if I'm not wrong. Um,
Still, yeah.
Yes, yes. Thank you, Dr. Mead.
Yes.
Yeah, and we also have Dr. Masood Sadiq as our session chair for this session. So we welcome him as well. And we welcome you all for joining this on the weekend on Sunday. And
Thank you, Dr. Safdar. Thank you.
yeah, that shows the commitment of everyone. So before wasting any more time, I'm going to hand over proceedings to Professor Sadiq and then to Dr. Hasnain Mirza.
Thank you very much, Dr. Safdar. I think without wasting any further time, I would be requesting Dr. Hasnain Mirza to go over. I think I can briefly introduce Professor Zahed Amin because he's one of the leading pediatric interventional cardiologists in the world. And I think he's a true aspiration and a big name in the field of pediatric cardiology. So we very warmly welcome Professor Zahed Amin. And over to Dr. Hasnain Mirza for his talk on PDA treatment in preterm infants, when to treat.
Okay.
Over to Dr. Hasnain.
Thank you very much. And everybody can hear me?
Yes, we can hear you well. I can hear you well.
Yes.
Thank you very much. So thank you for giving me this opportunity. When we decided that we're going to talk about PDA, I didn't know that there will be back-to-back PDA presentations. And this is a really beaten up topic. I don't know if there is anything left that I am going to add in today's discussion. But every time people talk about PDA, the discussion is treat or tolerate. So I want to just deviate from there. I want to talk about when to treat, because it's not really a treat or tolerate question. It's about what kind of PDA you can tolerate and when enough is enough and you need to treat. As a neonatologist, I have academic interest in learning about pulmonary hypertension and hemodynamics in preterm infants. So PDA treatment is my favorite topic. Rather than repeating the same mantra on tolerate, I will just talk about the indications for treatment. I am not for or against treatment. It takes me out of those two camps. I believe we need some objective criteria to evaluate these infants and customize the management plan accordingly. I can never answer this question, treat or tolerate PDA, because each baby is different. And my decision to treat or tolerate is based on a combination of clinical and echo criteria. I treat PDAs in the first week of life if needed. I can delay the treatment or decide not to treat. That all depends on the clinical assessment of that particular baby. I will share some insights with you, the way I practice. And this is not the only way. So if there are some variations, you feel like there are better tools available to make that assessment and decision, I will be very happy to discuss and learn those things as I present this topic. So starting with this disclaimer, there are no financial interests to disclose related to this presentation. And this table that you see on this slide, I took it from the most recent expert consensus report that was published by the American Academy of Pediatrics in May 2025. And the only thing that the message I get from this is more premature a baby is, higher the risk of PDA beyond the first week of life. So as you get down to like 24 weeks or less, 80% or more babies may have that PDA. And the question is always what to do with that. Based on the data, we know that PDA in preterm infants is related with all sorts of poor clinical outcomes. But then, astonishingly, about 15 years ago, we also started seeing this data that PDA treatment does not change those poor clinical outcomes. So whether you treat or not treat, these clinical outcomes are same. So that has started this whole confusion. And I am wondering, like, how to explain this. I know this is the data, but I can understand the statistical significance of this data, but I'm struggling to understand if PDA is really a factor that influences the clinical outcomes, why the PDA treatment does not change those clinical outcomes. So here are two plausible explanations for that. If PDA is just an isolated problem of prematurity, like everything else, IVH, NEC, BPD, then its treatment will just improve the PDA. It will not improve the other clinical outcomes. But the problem is that all these studies that has linked PDA with poor clinical outcomes, they have adjusted the data for lower gestation. And we know that PDA is independently associated with these poor clinical outcomes. So it's just not an isolated problem of prematurity with no links to the other poor clinical outcomes. So I don't really accept this explanation to explain the data. The other explanation is that there is a potential flaw in the study designs that show no benefit of PDA treatment. And the most important deficiency that I see is the lack of PDA profiling. So all of these studies are looking at PDA as a categorical variable, so yes or no. There are some shunts that are tolerable for a short period of time. There might be shunts that are tolerable for a longer period of time, but there are other PDAs that need immediate intervention. So I don't want to put all PDAs in one basket. And that's the problem in these studies showing no benefit of treatment, because they are just putting everything in one basket. The other problem is that the infants in the control group are not truly the placebo babies. They get the treatment, so they allow that crossover. And I know statistically you can adjust for that, but it's not a clean data after that. The third problem that I have with all these studies is the variations in the treatment response. So all babies, like, they are grouped together as PDA, whatever kind of PDA they have. The treatment group is also put together, whether that PDA closed or it only shrink in size or it did not change. So if you are putting all those babies in that one group, calling it treatment group, and expecting that outcomes will improve while the PDA did not close, it does not make sense. So I think there is a study design flaw with all those studies showing no benefit of PDA treatment. And one other variable that kind of gets overlooked is the timing of treatment, early versus late. So if you are treating PDA after the first week of life, please don't expect that IVH risk will improve by that treatment. because the IVH risk is there in the first 72 hours of life. If the PDA was there causing major variations in the cerebral blood flow, you will end up with IVH. Whether you treat it or not, it will not improve the IVH. Similarly, if you leave that duct there for 2 weeks or more, you have already started the lung injury that will develop into BPD. Don't expect the BPD will improve. Same thing for the neck. So it's the timing of that treatment that was not considered when people concluded, looking at that data, that PDA treatment does not improve the clinical outcomes. This is another important graph that people show. PDA will spontaneously close in majority of preterm infants over a period of time. So why shall we treat? However, this graph is an example of a glass that is half full and half empty. One argument could be, without treatment, more than 50% infants born at less than 26 weeks will be exposed to shunt-related injuries for more than 2 months or even longer. I'm not saying that one argument is better than other, but there are two interpretations of the same data. I personally don't feel confident to decide treatment based on this graph, because this graph is just the description of a natural or a temporal profile of the ductus. It really doesn't tell me that it is okay not to treat PDA for over 2 months because 50% of these babies will spontaneously close their ductus. Since I'm confused looking at PDA data, I can try a different tool to answer that clinical question. This is a simple 2x2 decision matrix. Administrators and managers use this tool for objective decision making. And I'm not saying this is the right strategy to adopt in clinical practice, but this is a risk mitigation tool to avoid high-risk mistakes. So if I plot time on the x-axis and shunt significance on the y-axis, we get these 4 scenarios that you can see in these 4 boxes. I'm super confident for not treating the baby in that green box. I know that PDA will not affect the broader clinical outcomes. So I am really not worried about leaving that PDA to close spontaneously. And I'm also somewhat confident to treat that baby in that red box because I don't want to leave a significant shunt for a very long period of time. I know we will end up with more problems later on. But even to use this kind of strategy or approach, I need to define a significant PDA and I need to define prolonged. And there is no consensus on these two things yet. So we are trying to define significant PDA and we are trying to define what is prolonged. So not really very helpful here either. Let's try to understand what the significant PDA and prolonged PDA can do. This slide is important to show the impact of ductus on pulmonary, systemic, and cerebral circulation. If PDA is not causing pulmonary overcirculation, that insignificant PDA, and I'm happy to ignore that. A large PDA with significant left to right shunt will cause pulmonary overcirculation that increases the risk of pulmonary hemorrhage, heart failure, BPD, and death. If you look at the time factor, as the infant develops pulmonary overcirculation, myocardial compensation can maintain the systemic perfusion. However, if the shunt is unrelenting and prolonged, that myocardial decompensation can lead to systemic hypoperfusion. And at this point, it becomes prolonged PDA, and the risk for poor clinical outcomes steeply goes up. A significant shunt also affects the cerebral hemodynamics, increasing the risk for IVH or PVL. I know expert panel report by AAP published in May of this year is suggesting to delay the treatment beyond 2 weeks. But that's very arbitrary. That recommendation is generally acceptable, but it's not precise. How is that helpful for an infant with pulmonary hemorrhage due to a large PDA in the first week of life to not treat for another week? So I think the decision for treatment should be based on individual clinical assessment rather than any general guidelines. I like this slide because it's not saying treat or tolerate, but it highlights a balance that can be tilted by different variables. You can see the rationale to treat or tolerate PDA. However, as the hemodynamic significance of the ductus goes up, I get worried. If there is a large left to right shunt with pulmonary edema, and you start seeing pink tinge secretions coming up through that endotracheal tube, this baby may end up with frank pulmonary hemorrhage. In this situation, offering early treatment is very appropriate, in my opinion, even if that baby is like 3 days old. On the other hand, there is another baby with large PDA, 25 weeks on CPAP, oxygen requirement is less than 30%, your perfusion is adequate, you're tolerating feeds, that is okay to delay the treatment for that baby. So treat or tolerate shall be decided on case-by-case basis. It's not justified to say that PDA needs no treatment in the first 2 weeks of life. This is another illustration to explain our case-by-case approach. A ductus can be tolerated if pulmonary overcirculation is compensated by the myocardium and your systemic perfusion is maintained. However, this balance is fragile depending upon the 4 variables listed in these green boxes here. If you need Lasix to treat pulmonary overcirculation, if you need to go up on your ventilator settings and oxygen requirement, if you need to use dopamine to maintain your systemic perfusion, please pay attention to the echo variables for objective assessment of volume overload and decompensating myocardium. That baby may need treatment sooner. And this is a thing that most people do not talk. We are all already confused. So I'm adding another variable in that confusion, is the different types of the ductus. So every ductus, you cannot just make that decision based on the size or one variable, because even the structural variation will affect the hemodynamics of that ductus. If you look at the variant in type A, D, and F, you can imagine their hemodynamics tolerance will be better even if the ductus is of the same size. And I'm sorry for this busy slide. You can see here 2 columns in this table. One is for clinical criteria and the second is for echocardiography criteria. My friend Patrick McNamara published this first time in 2007 in order to promote objective assessment of the PDAs. Most centers were not able to use it because some of the clinical variables are very subjective here. For example, assessing the radiologic evidence of increased pulmonary vascularity or looking at the gastric aspirate. We don't even check the gastric aspirates anymore rather than using it as a marker for significant PDA. Similarly, if you look at the chest x-rays, they all look very similar, especially if you're lung recruitment is not optimal. It's very difficult to assess the pulmonary edema just by looking at the chest X-ray. Similarly, some echo variables in this system are also not routinely available in most centers, like mesenteric, cerebral, or renal artery Dopplers. Many cardiologists don't even believe in the integrity of all these variables, especially in the preterm infants. They don't know what are the normal reference values for preterm infants. So you may get a number, but you don't know what to do with that number. I think it was a good proposal, but not suitable to use in routine clinical care. You have to be an echo expert to use it. To the best of my knowledge, no one is using this criteria in clinical practice. I put this table here in the presentation because the criteria that just came out in the American Academy of Pediatric practice guidelines on PDA, they have a modified scoring system right here that came from the original 2007 McNamara's scoring criteria. Even on this modified scoring system, there are a lot of subjective criteria. There are only two things which are more objective that I have, check marked here with that red. But most of the things are very subjective. And to use this, you have to define the threshold for high CPAP. What is high CPAP? CPAP of 6 is high or not? Or is it 7 or is it 8? We don't know. And what is high FiO2? Is it 30% or is it 40%? And if it is not 30%, is it okay to leave that PDA and treat it? This is also, there is a lot of subjectivity in this. So it looks like it's a good starting point, but I don't think it is a very comprehensive tool or even a precise tool to do your clinical assessment of PDA. And this is not only one scoring system. There are at least 6 other systems, including the one that we have published in 2019. None of these systems are perfect. They have, all of them have their own pros and cons. But you can look at that, and whichever is more suitable, you can try in your clinical practice. But I like it just because it gives me an objectivity when I'm assessing the baby. So I'm not describing something. I can use a scoring system to make it more objective. So any one of these scoring systems may be helpful for that purpose. I will not spend too much time on this slide. Here is a proposal for PDA follow-up in the outpatient clinic. These guidelines were meant for term infants, children, and adults with PDA. These guidelines are not applicable on preterm infants, but I wanted to show this slide to emphasize the risk of pulmonary vascular remodeling with time, especially if there is a significant PDA left untreated. So here is a quick summary to highlight the important points. We understand that treating all infants with PDA is unnecessary. Conservative PDA management is appropriate for a selective group of infants based on their ductal profile or the duration of shunting. Medical management shall be considered for infants with hemodynamically and clinically significant ductus. And if medical treatment is unsuccessful, we shall not call it treatment group. It is still unsuccessful treatment. So reevaluate that infant to determine the hemodynamic and clinical significance and refer for device occlusion or surgical ligation at that point. And I have these 3 cases that I can share with you, and you can use your phone to scan this code and join this poll to see if you want to treat or tolerate this kind of ductus. So this is the case one. It's a baby who is 23 days old, was born at 25 weeks gestation, weighing about 930 grams. That baby is on CPAP of 8, so you can call it high CPAP. And FiO2 is 30%. The blood pressure looks okay without any dopamine or D-vitamin. Your creatinine is on the higher side, but still in the reference range, and baby is tolerating full enteral feeds. When you look at the chest X-ray, that looks like this. On your echo, this PDA is 2 millimeter in size with a PDA Doppler at 3.1 millimeter per seconds. LA to AO ratio is 1.2. PDA to LPA ratio is 1, and LVZ score is less than 2, which means there is not significant left atrial or left ventricular dilatation. Will you treat this baby or manage conservatively?
Are you asking a question about this?
Yes. So there is a code here. You can use your phone and join the poll.
Yeah, you can scan the QR code, and then there will be a survey question which you can submit. I just did one mine.
So if you use your phone, use the camera, and it will take you to the survey. So it looks like at least 75% of people, they would like to manage conservatively. And again, this is not a right or wrong answer. This is how do you want to manage this?
You want to discuss this case, or you want to see what people are saying? Because I think majority of the people are in this group from Pakistan, right? And
right.
PDA closure is not very famous there, so it could be very skewed. And you know what I'm saying?
If we started discussion.
No, I mean, I was just trying to explain this, that the information you will receive based on this code, it could be really skewed, because I know only in Peshawar that they had done, I don't know, maybe now Masood or somebody else have done cases, but till last year when I was there at the APPCS meeting, only Peshawar had done a couple of cases or few cases in premature babies. So I think that it all depends upon what is available, so tolerances depend upon what's available, right? I mean, we were able to live our lives without iPhone, and you cannot live now an hour without them. So and then we were able to live on beepers, and before that on telephones, which were at home only. The tolerance is what's available, right? So I think that information could be completely skewed on this. I do agree with this patient that there is no LA enlargement in this patient. Patient is not on diuretics. If you want to wait on this patient, I will agree with waiting on this patient, to be honest with you.
I think, Zahed, your point is well taken. I think majority of audience here is from Pakistan, and I take your point, but I think looking at the clinical data, we can discuss whether anywhere in the world you would be actually doing an intervention on this case, whether you have availability or not. I think I would certainly vote for conservative treatment here, and that's what I did. But I think one could, as you said very rightly, that even you would probably go for conservative treatment based on the fact that the child is not on diuretics, he's tolerating feed, his creatinine is normal, he's not on any infusions, he's maintaining his blood pressure. And even if you look at the echo, I think probably one would go for a conservative treatment, whether in US or Pakistan.
Right. No, I personally would completely agree with what you said, and I said that just before you. had your wonderful remarks about this. That yes, I mean, I think this is a patient you can definitely wait on. I think there is a huge. Sorry, go ahead.
No, go ahead.
Yeah.
Can I make a point, Dr. Hasnain?
Yes,
Yes,
please do.
Yeah, I think the tolerate means not to treat at all, whether this is pharmacological or otherwise.
Right.
It did not mean the intervention.
Right. So
am I right?
Yes, you are right. But all these choices people discuss whenever there is an echo report saying that this baby has moderate to large PDA, and this is a real case that we had about a year ago, and there was a lot of discussion about it, just because we were like after 3 weeks, and they were worried about the oxygen requirement going up. We ended up not treating this baby, and this ductus closed spontaneously in about 6 weeks. But this baby went home without any oxygen, without any IVH. So I know that that was the right decision, because we did not see any fallout of that decision not to treat. So this baby was never treated.
I think that was the right decision and the right course of action.
Right.
So I'm going to be a devil's advocate now on this side. I understand about this, and I think Masood can then add on to this too. So in our practice, since the small PDAs have been now, we are told, forget the premature baby PDAs, for the thinking about older patients PDA, the criteria to close has changed quite a bit. That if you cannot hear the PDA and you find the PDA by echo, we don't close it. Okay, so absolutely, I tell the parents 100% this patient doesn't need closure. There are some parents who still want it, very few. And the one thing we need to do in those patients, and I always tell all of my colleagues, is you have to discharge them. If you don't need to close the PDA in a 3-year-old who is small, then they continue following. Come back in 2 years, come back in 2 years, come back in 2 years. That to me is not right. You cannot follow a patient whose PDA you don't need to close, or it doesn't need to be closed. One thing. Second is the PDA that we close in these patients is a PDA that you can hear. That's the one criteria that is allowed by American Heart Association, by the way, that if you can hear the PDA and they may be slightly enlarged, you can close it. So what criteria we use it? So if you use that criteria, so either you're separating the premature babies from older babies because you think the risk of closure is higher. Now, if I were to tell you that actually the risk of closure in a premature baby is lower than in actually older babies. So, you know what I'm saying? So Hasnain and I work together here at Advent Hospital for the last 5.5 years that I've been here. And we have done roughly 40 PDAs, so now premature babies, anywhere from 700 grams to 2.8 kilos, to be honest with you, some of them. And we haven't had any issues with those, I hope, that I know of, to be honest with you. So the question is, how do you want to separate premature babies? Because you do hear the PDAs in them, 100%. And you don't. And I could tell you also one thing. I've closed more PDAs here after they were discharged as a premature babies than I've closed as they were premature. Because, and that always bothers them to me. These guys come. This patient may have gone home on no oxygen. But I see patients who come on oxygen 3 months after they were discharged, preemie babies, and not one. I can tell you 5 in the last 5 months, maybe, on oxygen dependent, and they have a gigantic PDA still, and we close it. Then it is more difficult to close. That PDA is way more difficult to close than if the baby was 800 grams, to be honest with you. So I think there has to be a fine line. I think, Hasnain, your talk was fantastic. To be honest with you, balanced, but I don't recall in the last 5.5 years closing a single PDA on a 24-week baby who was less than a week old. Nobody sends it.
Yes, so you're right. That most people have the tolerance towards PDA, especially in the first week of life. But we are not talking about device closures only. We are talking about the medical treatment as well. So I have treated babies in the first week of life. And the most recent one I did was just like 2 months ago. And I'm going to show that baby here as well. to see how many people will agree with me to treat that baby. That was only like 6 days old. But let me bring the second case.
Yes, Stan, please do. I think what Professor Zahed is talking about was the duct in larger context,
Right.
older children as well, and the indications and so on. But I think when we talk about a preterm PDA or a preterm large PDA, we are talking about a totally different context. So please
Yes.
go ahead and show us the second case.
So this is the second. I have the third. That's the last case that I'm going to show at the end. This is the second case, and this baby was born at 24 weeks, is now 77 days old. Baby's weight is 1,280 grams, and the baby is stuck on high frequency ventilation with 60% oxygen. The blood pressure is relatively on the higher side. Is requiring sedation because baby is on high settings on the oscillator. The creatinine has slightly gone up. Baby is tolerating the feeds through the NG. We did the sepsis workup at that time. All the cultures were negative, but baby was on antibiotics because of the acute clinical decompensation. This baby was already treated with 3 courses of steroids. And required random doses of Lasix here and there to help with ventilation. When we did the chest X-ray, the right middle lobe has some infiltrates, and that's why people were thinking maybe baby developed some kind of pneumonia. We did an echo on that same day, and the echo showed this huge PDA that was 3.8 millimeters at the time, with the Doppler speed of 2 meters per second. And you can see there was significant left atrial and left ventricular dilatation, although the baby's cardiac function was okay at the time. So the question is, please scan this QR code and let me know if you would be willing to treat this baby at this point.
I think this is let everybody vote for that, but this is the other extreme that you have shown.
Yes.
When we talk about a large or hemodynamically significant PDA, I think this particular child would fulfill all the criteria, both clinical as well as echocardiographic criteria, to call it a hemodynamically significant PDA. And I think decision will be fairly simpler. Of course, this baby would need treatment. The only question then would be that would you go for medical treatment first, or would you ask Dr. Zahed to go ahead and close this using a device, or if we don't have the device option, we would ask our surgeon to come in and ligate this particular duct. I think that is what needs to be deliberated or discussed in this particular patient. The question whether he needs treatment or not, I think, is very obvious.
Right. Thank you very much. So in my mind, I'm also very clear that this is the baby who definitely needs treatment, and this treatment is probably late. It should have been done sooner.
Yeah.
77 days is too late. But there were people who were debating that we don't need to treat this PDA. And I have to really stand up for this. And they still wanted to try medical treatment first, but this baby finally got the device closure. And that was about, I want to say 4 or 5 months ago. It was a device closure.
Good.
Good.
Yeah.
Zahed,
So
you want to
are
add
you
on to
saying
that?
saying the medical treatment failed?
Yes. And the reason for that was,
Yeah.
Dr. Zahed, it was like too late.
Yeah. Of course. So what did you exactly try? Ibuprofen or paracetamol?
Ibuprofen. We kind of walked away from indomethacin. We are not doing indomethacin anymore.
No, I didn't say indomethacin. I said paracetamol.
No, we don't do Tylenol either, especially for the cases like this. We used Tylenol, but that's not the preferred. It's not the treatment of choice here. We use ibuprofen.
Thank you.
Can I bring in a point here that in a baby like this, would you obviously you are a neonatologist and myself and Zahed are cardiologist. So the approach has to be a joint approach, but the the mindset might be slightly different. As a cardiologist, I would think that if I see this echocardiogram with such a large duct and baby is already 77 days with all the parameters that you have given, I wouldn't really would have even tried Brufen. I would have gone straight for either device closure or surgical ligation. Now,
Right.
how would you decide clinically or on echocardiographic findings which patient that you would give a trial of ibuprofen or paracetamol, and where you would go straight and go ahead, or would you try medical treatment in every preterm, and if this has failed, only then you would go for a device closure or surgical ligation?
So to answer your question, I covered this baby on a weekend call. So it was not on my service. I just came in and I saw all of this, and I kind of diverted the direction of management. I kind of bring that whole focus back on the PDA. It was more on that the baby probably got infection. That was the treatment, and that's where the people were more worried about, rather than worrying about this kind of ductus. When I saw that ductus, and I thought I have put a video clip here, but it's probably a picture, but it was just pounding, and I just could not see any way to save this baby's life without doing something about this ductus. So I brought that up, but it was another colleague of mine who was on clinical service, and he did not see it that way. So there was a debate. We had discussed it in the meeting, and there was a divided opinion. So they decided to try medical treatment first. But in my opinion, at this age and for a PDA like this, it should have been straight to cath lab. And in my opinion, this should have done maybe a month ago, before we get to the high frequency oscillator and 60% oxygen, because that's like just a delayed treatment here.
Masood, one of the things that that essentially is done here, or probably in any institution that I know in the US, is that if the baby we think needs to have the PDA closed, medical treatment is like 99% of the time done once.
Yes.
Give a chance that
Yes.
it close, and if it's not doesn't close, sometimes they give second line of treatment. In my discussion with Hasnain, everybody else always says, please do medical treatment, but if that doesn't work, then let's not wait on this. So,
Yeah, I personally tried that in the first 4 weeks of life.
Yeah,
After the
correct.
first 4 weeks, I have not seen the medical treatment being successful.
I agree with you. So I think I would say 80% of the patients whose PDAs that I have closed have had medical treatment ×2. Second run, actually, one round it didn't work. They tried a second round, didn't work, and then they say, okay, you know, this is not going to work. And it's still, I think, it's very timely that we still do it at that time. So from interventional perspective, the best time to close is in the first 3 weeks, because the PDA is the longest at that time. As the patients get older, the aorta gets bigger, it starts forming some ampulla, which you don't want in these patients. Then the PDA gets shorter in length. Then you don't have a device. The longer the PDA, the easiest it is for us to close it, because you want this all intraductal. You don't want device hanging in the aorta because you're going to cause coarctation, or in the PA because it's going to cause LP and narrowing. So have 99% of the time you want the device intraductal, and that's the best time to close. It is in the first 3 weeks. And in fact, as Hasnain says, in fact, in the first week is probably the easiest. People, I think, worry about the size of the baby, the management of the temperature in transferring, you know, because the babies can get colder much easily in them. You take them out of the environment, the protectiveness and all that stuff. We do a lot of things in the cath lab is the hottest when we do premature babies, literally 85 degrees. And we have like heater on, we have under bare thing on. So we try to keep the baby 97, 98 degrees, 100% of the time. Blood is available, warm blood if you need to give blood. We don't even give cold blood, all these things. But even then they still can get colder and stuff. So I totally understand their protectiveness. Our discussion with them always is that if the medical line of therapy has failed, and you do believe that this PDA is being harmful to the patient, not a PDA that is kind of there, but not bothering them, then we should close it. I think there is a subset of neonatologists who still would not want to. They think it doesn't make any difference. And Hasnain pointed that out very nicely in the beginning of his talk. That's the one area that we need to break the ice.
Thank you, Zahed. That was very comprehensive. I think then it brings a couple of questions here. You said that the best time to close a PDA technically, because the duct is long and elongated and the aorta has not grown, so you find it easier to close it percutaneously. But if you look at the literature, many people would think that the first 2 weeks we should be restricting ourselves to conservative treatment. And if anything, I think medical treatment should be offered. And when it comes to any intervention, generally people would wait until these babies are over 2 weeks. And then the second point would be the gestational age. Like this particular baby was 24 weeks and then had gone up to 77 days after being born. But vis-a-vis another baby who is 28 weeks or 30 weeks, what is really the cutoff time that people would think that we need to go for, or we should not be doing it percutaneously or surgically, depending upon the gestation? Over to Hussain.
So yeah, I think there is a slide by Hasnain. It tells you if you are
Yes,
less.
I have the next slide because the
Uh-huh.
American Academy of Pediatrics just published to delay the treatment for 2 weeks. And the
2
next case is where you don't want to delay, because I was worried I will lose that baby.
Yeah, so I want to just commenting on this. So this was essentially a sliding scale when the PDA premature babies PDA started their closing. If you look at the literature, surgical closure was very good, but it was fraught with a lot of complications. So by 2004 or 5, neonatologists stopped sending the patient to surgery. They said we'd rather tolerate than to have thoracotomy, and so many issues they had with them. I don't know, maybe the older surgeons were doing a better job many years ago. We were expecting more. And then initially when I got involved in PDA closure, it was 2016, 17. At that time, we thought PDA closure is best after 6 weeks of birth. So everybody, we were saying if it's above 5 weeks, we should attempt closure. Then it came out, 3 to 5 weeks is the best, 100%, because it was a better outcomes, less chance of having arch gradient, less chance of having, and then they started doing this, and then more and more data came out. And like Hasnain said, that the best time to close is actually the first week, if you are worried about intraventricular hemorrhage and stuff like this. And we also thought, I mean, depending on, I don't do as many cases, that there are some of my colleagues in the US that do it. So when we set a consensus, when we had an Abbott sponsored meeting, was actually the first 3 weeks had the best possible outcome. So that's what we gear towards. But I think the neonatologists should and must have a much stronger say on this, what's the best timing. And if you based on that, then Masood, you're 100% right. They are going to tell you wait up to 2 weeks at least, barring some cases that Hasnain said he's going to show to you.
Sure.
So this is the third infant that I had on my service about 2 months ago. This is the baby who was born at 26 weeks and was doing okay on conventional ventilation, low oxygen requirement. And then the oxygen requirement started going up and it reached up to 45%. And then we started seeing the pink tinge secretions coming out of the endotracheal tube. The blood pressure would not stay in the acceptable range. So the baby was on dopamine, because when we tried to stop the dopamine, the baby will be oliguric and anuric. So that low dose dopamine was so much important. The creatinine went up to 2.1. Baby was tolerating some feeds and was still on TPN. The blood cultures were all negative, but baby was on antibiotics just because the oxygen requirement started going up. And that happened like between day 3 to day 6. This is how the chest x-ray looked like. And even on this chest x-ray, I can say there is significant pulmonary edema. And when we did the echo, the PDA was 3.4 millimeters. And the Doppler velocity across this ductus was less than 2. And there was already a somewhat left atrial dilatation, not huge, and the LV dilatation was still not there. So although I look at these things to assess the volume overload, but this baby is only 6 days old. And I'm looking at this ductus and the pink tinge secretions coming out of the endotracheal tube. So the question is whether we need to be a bit more aggressive with this baby or just be conservative and give it another week, because the baby is not 2 weeks yet.
I think this very much brings what Zahed was saying earlier on, that the decision, there should, historically we would say 6 weeks, then 4 weeks. Now we are saying 2 weeks. I think it's very individualized. It really depends upon the baby. And on that particular baby, I think there should not be any restriction of 2 weeks, 1 week, or 3 weeks. Look at this particular patient. I think anybody looking at this criteria would recommend closing this PDA. And I think, and I would say that if your creatinine is already 2.1, you're already on dopamine, your oxygen requirements are high, you are getting this pink tinge on secretions as well. I wouldn't even try ibuprofen. I would just go ahead and ask the cardiologist to close it, or the surgeon to ligate it. Zahed, what do you think?
I think I agree with you. I mean, as long as the baby is stable. What about the SATs? I mean, sometimes they ask us to close on the baby SATs are like 45-50% on high, ventilated and all that stuff. So yes, I agree. It just should be closed 100%.
Right.
Professor Masood Sadiq. Can I make a comment?
Yes, please do. Sajjad, please do.
Yes, I think we will close it aggressively, but with the medical treatment, I would go with ibuprofen as a standard medical treatment,
right,
before thinking of any device closure.
Right.
Okay.
I think that is standard practice in the NICUs.
Right.
And there is data to support that many of these would actually, despite being so large and having derangement of renal function and myocardial dysfunction, they would still close with ibuprofen?
Yes.
Yeah, I think so. Yes. This is what our experience is.
Okay.
Right.
Okay. Good.
So,
Sorry.
I was debating with my friends, and I was just not comfortable leaving this baby untreated, whether the baby is less than a week or not, because I was worried if I left the baby untreated, I will end up with frank pulmonary hemorrhage, and then I will not be able to capture it. So I went ahead, and on the same day I write the ibuprofen high dose. People were telling me that the creatinine is high, you cannot give the ibuprofen, it's not, it's going to be nephrotoxic or whatever, but I did not stop. I thought the reason the creatinine is going up is the ductus. It's not the other way around. So I treated it with ibuprofen, and this baby responded to that.
I think you are very right, Dr. Hasnain. This is what I would have done as well. This baby is at the verge of massive pulmonary hemorrhage, and that would have been a big disaster.
Hasnain, just want to comment real quick. You know that with the new AAP guideline, this case probably will be very hard to convince people to treat before 2 weeks, even with all the findings we just talked about.
Yeah.
People will argue, no, we can still give more chance to going up on mean airway pressure, just stopping hemorrhage for now and just waiting it on. So this is still very debatable. The third case, I mean, I agree with the first two cases. I mean, the way we handled here, we are having hard time convincing anyone to treat before 2 weeks of age, since we have new AEP guidelines.
That's what the problem is.
So one thing, I think the
question
that should come on this would be, I completely agree, giving a medical treatment. If the medical treatment failed and the baby now is 11 days old, would you wait? That's what I mean. I mean, I am completely for medical treatment ×1 in this scenario. And if that doesn't work, then we should close it, not say, let's give another second line of therapy to see if it will close or not, because the patient may even get worse, because once you gave this ibuprofen, I'm sure the creatinine didn't like it either.
No, actually, creatinine improved.
Okay, even better. Okay.
Yeah, that's the problem. The problem is, so I understand the hemodynamics because I have my academic interest in this area. And then I spent a year in the echo lab. looking at the echoes of pulmonary hypertension and ductus. So I actually understand how the hemodynamics change. The problem is when there is an echo report that says based on ductal shunting, there is pulmonary hypertension. 80% of the neonatologists don't want to treat that ductus. Actually, that is the ductus that should be treated because your pulmonary hypertension is not because of increased vasoconstriction, but it is because of excessive pulmonary blood flow. You need to stop that. So seeing a pulmonary hypertension on that echo report is kind of, it stops them from treating because they get worried about pulmonary hypertension. They think it's a pop-off valve that is helping me. Otherwise, if I closed it, the pulmonary hypertension will become a problem.
I think, Hasnain, you are very right. And they also need to see whether the pulmonary hypertension is suprasystemic or not.
Yes.
Where is the shunt? That's important. If it still remains left to right shunt, then I think we are better off treating it.
Right. I actually saw somebody starting nitric oxide because of that. And I said, no, you are just going in the wrong direction.
Exactly.
You should not get the nitric oxide.
Yes.
I think coming back to what Dr. Safdar was saying, that current AAP guidelines, I went through them as well. I think you have to still individualize patients. I know guidelines are always guidelines, and they need to be respected. But I think if you have a baby like this who is still not 2 weeks, and as I think Zahed pointed out, if at 11 days of age you are still stuck with the baby, are you not going to treat that child despite IV ibuprofen if the child did not improve? So I think every baby has to be individualized. And I think AAP guidelines do not restrict you or stop you from individualizing every patient. Rather, they support that concept. Of course, that 2 weeks is there, but I think they support that concept of individualizing every patient's treatment according to the clinical echo and lab parameters of that particular patient.
And I totally agree, all the points made, but the counter argument, I'm just going to be a little bit devil's advocate here. The counter argument we will get is that if Hasnain has waited for another week, we might have still closed the PDA. Who knows? Because we don't know that. We don't know if it was the treatment or if it was the time we gave to the baby and the PDA got closed. Because a lot of people argue like 6 days of life, many babies will have large PDA and many babies will have high creatinine for one reason or another, may have pulmonary hemorrhage because they might have given us 2 doses of surfactant and there is a decrease in pulmonary compliance. So there are many factors. So the counter argument, I'm just trying to advocate for them as well. But I agree. I mean, I think these guidelines, they don't,
But Safdar,
they're
can I
not
come
written
in?
on stone.
Safdar, can I come in?
Yes, Dr.
Yes,
Junaid,
please.
go ahead.
Yes, please, Dr. Junaid.
Yeah. Good evening, everybody here this evening. So my comment is that the AAP guidelines not saying that what we are discussing, that you should wait for 2 weeks. It is clearly written that usually you should close after the 2 weeks. But if a baby has cardiorespiratory compromise, you can treat the baby. So so this is the way the guidelines always written, that as Professor Masood said, that we have to individualize the patient. And it is very clearly written that it is usually, yes, because all we discussed already in other 2 or 3 cases, and we all know that usually we close after the 2 weeks of life. But in this case, it is cardiovascular compromise and everything is going in favor to close it. So why not? So, but again, we will try the medical treatment first before go to any device or surgical treatment.
I agree. I think we have to try medical treatment, and 100% agree with, like Masood was saying, that guidelines are always guidelines. They're trying to tell you what you should do under certain circumstances. Patient is a patient. We always have to treat the patient.
Well, thank you very much, Dr. Zahed. I think Dr. Safdar, if there are any questions that we need to respond. Otherwise, I think we had a very comprehensive discussion, excellent presentation by Dr. Hussain Mirza, and of course, very pertinent comments from Professor Zahed, Amin, Dr. Sajjad, Dr. Junaid, and all the colleagues, including yourself. So the time is there now to close it. But
I think there are two questions in the
please.
There are two questions in the chat box by Dr. Ferry and someone else, Dr. from PIC. Two questions in the chat box.
I think we can respond to those questions very quickly.
Yes.
About if duct is shunting right to left, will you still close or give pulmonary vasodilators? I think if the duct is shunting right to left, of course you will not close it. And of course, depending upon the etiology, if there is no underlying lung pathology, of course you have to see whether there is a lung pathology or evidence of septicemia. But I think this point was earlier raised about suprasystemic pressures. So if you are shunting right to left, of course you will not close the duct. And the second question is also here that drugs that can we use drugs that pulmonary vasoconstrict here to our setup and circumstances for the treatment of a large PDA. This was from Dr. Mukhtar, I think.
No, Dr. Amjad Mahmood.
Okay. Hussain, you want to respond to that? Can we use pulmonary vasoconstrictors here?
To know our setup and circumstances for the treatment of large PDA. Yes, this is not a question. This is more of a comment, and I 100% agree with that. I mean, I am lucky to work here where we decide to do device closure tomorrow, and Dr. Amin is available. We can start planning tonight, but that's not available even in every hospital in the US. So we practice in a system, and system-based practice is a way to go. We cannot apply the standard of care from US hospitals to a hospital in rural Sindh. But whatever the resources are and whatever the guidelines are, the message that I had for this presentation was that yes, guidelines are generally acceptable, but individual assessment for every patient is still the most important thing.
I would just add one more thing before closing it. I think we have all agreed upon that the first option always is going to be medical treatment in majority of these patients. That can be ibuprofen or paracetamol. And if it does not respond to that, only then we would be going for an intervention, which depending upon the availability would either be device closure or in certain circumstances can be surgical ligation. So I think every patient needs an individualized treatment. That's the consensus, and that individualized treatment would depend upon the whether the PDA is significant or not, and that significance is both clinical, echocardiographic. I think one thing which we have not highlighted very well, considering our own population, is the role of echocardiography. Majority of the places in Pakistan do not have that facility of advanced echocardiography by a pediatric cardiologist, and our neonatologists are not trained in echocardiography. So I think one must sort of try and see if we can help our neonatologists to learn that. And I think a high quality echocardiography is crucial to the management of these patients with PDA.
Thank you. I think fantastic. Very good wrap up, Masood. Thank you so much.
Yeah.
Thank you. Thank you very much.
Thank you very much.
Yeah, Safdar, you could close it because you opened it.
Yeah, no, thank you. Thank you, Dr. Masood Sadiq. And thank you everyone joining on this very wonderful talk and very interesting discussion. And we will continue in collaboration with Dr. Sajjad Rahman. He is our actually focal person from academic neonatology group from Pakistan to bring everyone together here. So thank you all for joining, and we will continue these sessions every month, inshallah.
Thank you very much. Thank you, everybody. Professor
Yeah.
Masood, Sadiq, and Professor Amin. Thank you very much. And Hasnain,
Thank you.
thank you very
Thank you,
much.
sir. And
Thank you,
Safdar,
Hasnain.
just make sure that next topic is not on PDA.
Absolutely no. We literally kill the PDA.
Yes, it is
You
done.
can select another cardiology topic.
Yes, and
It's officially closed.
no more PDA till 2026.
Okay.
Thank you.
All right.
Yeah.
Bye, guys. Thank you so
Thank you.
much.
Thank you very
all.
much. I
Take care.
appreciate that. Thank you. Assalamu alaikum. Assalamu alaikum, everyone.